ပါတက်ရောက်လာတက်ရောက်လာကြတဲ့ဆရာတို့ဆရာမတို့အားလုံးမင်္ဂလာပါကျမတို့ဒီနေ့မှာ GP ကနေပြီးတော့ဥဆောင်ပြီးတော့ကျင်းပပြီးတယ်ပေါ့နော်ဒီ webinar လေးမှာတော့ဒီနေ့ topic ကတော့ Dermatology in Primary Care ပေါ့နော် topic လေးကိုဆရာ Sagar Patel ကနေပြီးတော့ပြောပြမှာဖြစ်ပါတယ်အဲ့တော့ကျမတို့ဒီနေ့အစီအစဉ်မှာ host အနေကို host အပြည့်ပေါ့နော်ကျမတို့ဒေါက်တာတင်းသူထိုက်ကျမဒေါက်တာဝင်းမြတ်ထက်ကြီးရဲ့ပြီးတော့ဆရာဆိုနီရဲ့ပေါ့နော်ကျမတို့ပြုလုပ်ပြီးမှာဖြစ်ပါတယ်ဟုတ်ဆရာဆရာကိုတစ်ချက်လောက်မိတ်ဆက်ပေးပါအောင်ဆရာ
ဟုတ်ကဲ့မင်္ဂလာပါဆရာမတို့အခုလိုချိန်ပေးပြီးတက်ရောက်လာတဲ့အတွက်ကျေးဇူးတင်ပါတယ်ကျွန်တော်ကတော့ဒေါက်တာဆန်နီအောင်ပါ Royal College of GP အနေနဲ့ကျွန်တော်တို့မြန်မာပြည် GP များကိုဒီ educational support ပေးနေတာပါဒီနေ့ကတော့GP general practice မှာလူတိုင်းနေတိုင်းတွေ့နေရတယ်ဒီ skin problem တွေပေါ့နော်ဒါကတော့ကျွန်တော် my colleague I'd like to introduce my colleague Dr. Sagar Patel Sagar, if you'd like to introduce yourself, thank you.
Good evening, everyone. Thank you for attending. I'm Dr. Sagar Patel. I'm a GP, and I will be giving a talk and a discussion around some common presentations, cases, and some background in dermatology and primary care.
We're happy for you to start now, Sagar. Thank you.
Okay. Thank you, everyone. As explained, I will be wanting to go through some background regarding dermatology in primary care. My plan for today is to try and explore and discuss a few topics. We're going to go through some background regarding dermatological history, and in particular some of the specifics and details of that. I'd like to talk about distribution, pattern, morphology, and this is extremely important in helping to better understand what a specific rash or lesion is and help communicate that to a colleague or to seek advice, to discuss with others, and also understanding how being able to explain and think about how a rash is developing also helps with the diagnosis. I wanted to just cover a few topics, cases that we often see, and I've decided to discuss dermatitis. We're going to cover a little bit about some superficial skin infections and also pruritus as a presentation and how we might want to investigate that. I then have one or two cases, and then I also wanted to share with you some useful resources that I find very helpful in my day-to-day work, in working in primary care, that are available to you and might be helpful for your line of work as well. So a little bit about me and my background. So I'm a NHS GP in London. I also work as a clinical fellow in dermatology. So that's a hospital-based job. And my focus is skin cancer and skin cancer surgery. So minor skin surgery for skin lesions. And then I also run a private healthcare business as well. And my NHS dermatology hospital is Chelsea and Westminster and West Middlesex Hospital, which are both in London. So before we start, I just wanted to explain a little bit about how dermatology is split in the UK, just to give a little bit of context and background. So for us, like all areas of medicine, there's the primary care, so in the community, and secondary hospital-based dermatology care. Initial diagnosis and treatment of most skin presentations occur in primary care. So the GPs will be the ones seeing a rash or lesion for the first time, trying to diagnose that and starting treatment. When it comes to skin cancer, again, it is typically the GPs who are identifying lesions of concern and then referring these patients into secondary care where definitive management takes place, which is typically surgical. Dermatology emergencies are rare, and generally speaking, a dermatological emergency is extremely severe, and these are normally seen directly in hospital, managed in hospital as an inpatient. when it comes to systemic treatments and biological treatments, so complex management, phototherapy, all of this sits within secondary care hospitals. So us as GPs don't see this and generally are not involved in those decisions. And long-term monitoring of conditions is generally shared between primary care and secondary care. So sometimes GPs will be doing ongoing skin cancer checks or skin checks. We might also take on some of the management of a chronic health, a dermatology condition. More complex dermatological conditions are managed long-term in hospital. So as in my role as a GP, I generally sit in the primary care, and for secondary care, I deal with skin cancer. So dermatological history. We have all learnt this at different stages of medical school and in our career. However, I wanted to rediscuss this because the importance of understanding and taking a really detailed history is really critically important. And the type of history we take in dermatology differs between whether presentation is a rash or whether it is a skin lesion. So starting with rashes, we really need to understand the history of a rash, but we need to go much further and understand details about how that rash has developed. So what I mean by that is really clarifying the timeline, and it's important to be specific. How many months, exactly when it started, to understand the start date. We then want to consider how it is growing, changing, spreading. The course of the rash is also very important because different skin presentations present in different ways. Some might worsen, some might better, some might become resolve and reappear. So understanding how the rash is evolving is really important, and it often requires quite specific questioning of the patient. We like to consider, are there any associated symptoms and features, typical features or symptoms being flushing, itch, discharge. Try and understand what factors are making this worse, and what factors might be improving the rash, and consider treatments, not just medications from the doctor, but also anything they've tried at home. Explore allergies, particularly non-medication allergies. Consider the medications, particularly herbal medications, multivitamins, supplements, and any other treatments they may have bought or found over the counter in the pharmacy. We like to understand the family history, particularly first-degree relatives. And then also always consider the social setting, occupation. So what that patient is doing in their day-to-day work, what is the environment? Is it a dusty environment? Are they touching chemicals? Are they touching products? Are they inhaling products? This type of background can be very helpful in understanding a potential cause of a rash. When it comes to skin lesions again need a very focused history. However, it's a little bit different. So we want to understand the history, we want to understand the timeline. But my main focus when I see these patients in hospital is understanding how a lesion has changed, in particularly thinking about the size, shape. So has it started flat and then grown? Has the color changed? Has it become irregular? The main symptoms we consider are pain, bleeding, crust. Those are the typical symptoms. Often lesions that are painful may be associated with conditions such as squamous cell carcinomas, actinic keratoses. Many lesions can bleed, and crusted lesions, again, can be either from a benign condition such as a seborrheic keratosis, or it could be a squamous cell carcinoma like the picture on the top right shows, with a very crusted surface that has probably bled recently. We like to understand the skin type. Now, different countries have different scales. In the UK, we use the Fitzpatrick skin scale. So this is rating someone's skin color. Fitzpatrick 1 is the lightest skin tone, so very light, fair skin, often ginger hair, freckles. Those are the types of patients that are most prone to sun damage. And then the scale develops into darker skin tones, brown, and then black. Exploring sun exposure is really important. how much sun they've had, what type of sun, where they have grown up. In particular, also, we try and ask about specific episodes of sunburn. So do they remember maybe when they were younger, an episode of sunburn where the skin was burning, it was flaking, it was blistering, because even one episode of severe sunburn can have quite a large impact on their future risk of skin cancer. I like to understand and ask about their occupation and their hobbies. Are they a builder? Are they a farmer? Are they a gardener? Do they work indoors or outdoors? Again, this is all about their sun exposure. Consider mum, dad, siblings, so first-degree family history, and what type of skin cancer they had. And then also consider immunosuppression, medications that have dampened their immune system in the past, chemotherapy, systemic treatments, long-term steroids. Distribution pattern morphology are very, very important. As I mentioned, this helps us understand the type of rash that a patient is developing. So when it comes to distribution, we are thinking about where on the body this is. And ideally, we want to be able to describe a rash, a skin lesion, so that someone else can picture it without seeing a photo. So we think about acral. So this is the distal, the ends of the hands, the feet, the ends of the ears and nose. Or is the rash spreading on the trunk? So this is the chest and the back and the abdomen. Consider whether the rash is following a dermatomal distribution. So this is along the nerve roots. The classic presentation of this is shingles. Is it on the extensor features or is it on the flexural areas of the body? This is very relevant in conditions such as dermatitis, so eczema, which presents on the flexures and in the extensor regions, depending upon how old the patient is. Is it follicular, so arising from hair follicles? Is it on its own and isolated, or are they clustered? So certain rashes and conditions cluster together. So they join up and they're sitting very closely to each other. Is it all over the body, generalized? Is it symmetrical, so we're seeing it on both sides, or is it only on one side of the body? And then there are some specific distribution patterns. Common ones being a herpetiform distribution. So this is grouped together. Cobonarizing is where you get a rash that develops at a site of trauma. So normally it's linear, so in a line. You also describe cobonarized rashes as ones developing out of scars, which are often linear as well. Photosensitive regions are the areas that are exposed to sun. So commonly thinking face, upper chest, lower arms. And then seborrheic regions. So this is sites of sebaceous gland presentations, classically ears, scalp, nose. Pattern of lesions is very important. So the common patterns that we focus on are discrete. Are they on their own, an individual lesion? Confluence describes individual lesions that have started to join together. Linear versus discoid, so in a line or a very clear round coin-shaped area like discoid eczema. Annular rashes are the rings. So this is commonly seen with fungal infections and tinea, such as the photo here on the right. You can see the raised erythematous red border in an annular region, in an annular pattern, with the central area still being erythematous but flatter. Target lesions are described as dartboards. So this is a target lesion. You can see the darker center, a clear white peripheral area, and then the final border being red and erythematous. So this is a classical presentation for erythema multiforme, which is EM. Morphology. Morphology describes the structure, and this is really important for lesions particularly. So the way we describe this is considering, is it a macule or is it a patch? So these are flat areas of skin, so flat lesions that we cannot feel. So they're non-palpable, we cannot feel them. And they're either small or large. And 5 millimeters is typically the approximate distinction between a macule versus a patch. But the key thing to note is these are flat and you cannot feel them. You then consider raised lesions. So we can feel them, they are palpable, and they're either a papule, which is very small, or they are nodules, the large red erythematous, larger bulbous type lesions. Plaques are flat-topped, larger lesions. So a classical condition that has plaques is something like psoriasis, which is raised, palpable, has a flat top, and generally quite large. And then we consider those lesions that are like blisters. Vesicles are very small. So here you can see these tiny little raised discrete bumps. So this is hand eczema, or also called pompholyx. You can have pustules. So in acne, they are often filled with the little areas of pus. And then you can have bulla. So these are the large blisters. So this description, macule patch, papule to plaque, vesicles to bulla, are really helpful in us understanding in our mind what the lesion is, and then we can discuss it, describe it, and this helps us guide the potential cause. Common conditions. So I've decided to choose a few conditions that we see often in general practice in the UK. I'm sure you're seeing very regularly locally to you. The management of these can then be applied to multiple other conditions. Eczema, dermatitis. So the names are used interchangeably. A very common condition. In the UK, 20 to 30% of all children have eczema and dermatitis. Starts to reduce as the children as we get older, but it's a really common condition. It has a huge level of severity, from mild to extremely severe, but the treatments of this are the same, and it's really important to understand the core areas of how to treat this condition, because the same themes of management can then be applied to many other conditions. Eczema and dermatitis have multiple triggers. So when you see these patients, always really be nosy and try and understand what is triggering this or causing this. And these are just some here of the many causes that affect eczema. I always think about atopy. So atopy is describing conditions such as allergic-based conditions. So hay fever, asthma. Hay fever, asthma, eczema often sit together. Think about allergens. Think about their environment at home. Think about whether they are stressed, whether they're sweaty. What is the family history? When it comes to presentation of eczema, it can differ quite greatly. And as I mentioned earlier, this is where understanding the location is important. So in infants, so very small babies, we generally see eczema affecting the extensor regions of the body and the face. So extensors being, for example, on the outside of the elbows, on the fronts of the knees. As a child grows up and gets older, they become a child, then they become an adult. Dermatitis typically presents in the flexural areas. So inside of the elbows, behind the knees, often around the hands and in between the fingers are classic areas as well. We like to understand the presentation. Is this an acute presentation or is it a chronic condition? Often eczema presenting very acutely might be triggered by more of a contact dermatitis. So this could be related to work or something they've got into contact with. While chronic eczema might indicate that this patient is having going into contact with multiple allergens or triggers over a longer period of time. Common symptoms for eczema is generally itch, but alongside itch, eczema patients can often have a number of other features. So always think about bleeding and discharge and crust. That is telling us that these patients are probably super infected, so they have now developed a bacterial infection. Is there lots of scale? Are there patches of eczema? And then look for areas of lichenification. So lichenification is thickened areas of skin. Lichenified skin normally tells us that this is chronic eczema that has been present for a long period of time. And alongside eczema or dermatitis, we always think about pigment change. Depending upon the skin type, so when I mentioned earlier about what someone's skin type, are they white skin, light skin, brown, black skin? Understanding their skin type also helps determine what the pigment change might be presenting as. So dermatitis in very light Caucasian skin often presents as erythema, so red areas of eczema, similar to this photo on the top right. In darker skin, eczema might be presenting as more grey-brown areas of inflammation. And over time, the pigment change can develop. So skin can become hypo, so reduced pigmentation, lighter, or hyper, darker areas of pigment in chronic disease. So how do we manage these patients? Education is really important for the longer term management of this type of patient. The patient needs to really understand what is happening in dermatitis or eczema and the core areas of treatment. First and foremost, always consider removing the factors that are triggering this. So are there pets that the patient's allergic to? Is it very dusty? Can they change the type of work they're doing maybe? In children in particular and babies, always ask patients to cut their nails very short. Often in children who are itching at nighttime, wearing long-sleeved tops, long-sleeved trousers helps prevent that child from itching overnight. In some children, we often put them in gloves at nighttime or even put a sock over their hands just to stop them itching overnight, because it's normally at nighttime where they are doing the most itch. We then consider what they are using in the shower or the bath. So how are they washing? And this is where soap substitutes are really important. Any moisturizer or emollient can be used in the shower. And this is what we recommend to our patients to wash. So instead of using normal soaps, they actually use a cream. If the skin is looking infected, you can also look at antibacterial washes. So we use things such as Dermal or Octenzin. Locally to you, there will be many other antibacterial washes. So we use this in the shower to cleanse the skin. I always recommend patients not rubbing their skin dry, but pat drying. This is less triggering and it's more gentle on the skin. So with the towel, just gently touch them to dry. And then we think about emollients. So these are the moisturizers. There are ointments, so very greasy. There are creams and lotions, slightly lighter. In a general sense, ointments are better for the skin because they have less additives, so less chemicals, less perfumes. However, not all patients like ointments because they are very greasy. If you have a child, the greasier the better. So greasier emollients are more moisturizing to the skin. And we always think about how much they need. So these patients need a lot of emollient, a lot of moisture into the skin. Many patients also find they prefer natural oils. So for example, things such as really pure coconut oil. So the coconut oil that you can eat, some patients use that as their emollient. So it's very pure, has no additives, and that can also be very good for the skin. I recommend patients with dermatitis to be moisturizing their skin at least twice a day, morning and evening, but ideally four times a day or more. The more you can put on the skin, the better the skin, the quicker it's going to respond. When it comes to management, emollients, soap substitutes in the shower and education are not always enough. So we then have to consider stepping up treatment. And this is where topical agents come into play. So antibacterial creams, fustic acid, for example, are really good. We use it twice a day, 5 to 10 days. It can help clear any superficial infection. We then think about steroid creams. Often, GPs in the UK, we use lower doses of steroids. However, it can be much better to use a higher dose steroid for less amount of time. And I'll show you this in a moment. We also consider combined products, antibiotics and steroids. So Fustin H, Fustabet is what we have locally. And then there are immunomodulator-based treatments. These are newer treatments, tacrolimus, pimecrolimus. So these are steroid-sparing agents, very good for the face, quite hard to come by. Often these are started by consultant dermatologists in hospital in the UK. Advising the patient on how to use a steroid cream is important. So they are using emollients and moisturizers. They're using steroid creams. The best guidance is to advise the patient to not put both on at the same time. So prepare the skin with the emollient. So put a moisturizer, emollient on, wait for 15 to 20 minutes, then apply the steroid cream. And then we consider oral treatment. So what else we can give them to help the patient? Antihistamines are very, very helpful in these cases. Patients scratch particularly overnight. So often adding a sedative, so a sedating antihistamine can be very helpful. In adults, something like hydroxyzine, chloramphenemine in children can also be helpful. So this helps them become a little bit sleepy. It also helps reduce the itch overnight. If you think that the rash is getting infected, add antibiotics. Sometimes you also need to add antivirals if there's a secondary viral infection on top. The steroid ladder. We've all seen different forms of this steroid ladder before. They start with mild, moderate, potent, and very potent. So when I mentioned earlier about which type of steroid to use, in the UK, often we are using mild steroids first in primary care, and then we step up. We go to Umivate, Betnovate, Dermavate. Generally speaking, very potent steroids should never go on the face. Potent steroids can go on the face, but in very short courses, 5 days, 7 days, and avoid areas around the eye. Mild and moderate are more safe to use on the face, and all of these can be used on the body. Something that you might find helpful to note, if you have Elicon, so Elicon is mometasone. This is a really good option if you think patients are going to struggle to apply Betnovate twice a day. They can use Elicon once a day instead, and that works really well. And then Fusibet is Betnovate with fustic acid. So this is a combined product, antibiotic and steroid cream. Trimivate here has steroid, it's also antifungal as well. So this is a nice cream as well. I've put on here 2 resources that you can access. Both of these are on YouTube. There are some really good resources out there for eczema, and these 2 in particular can be very helpful. This one on the left, atopic eczema, is great to show children who want to understand what eczema is. Also very good for parents to watch. And then this link, which is from the British Association of Dermatology, is very good on how to use topical steroids. So the doctors can look at it, the nurses can look at it, patients can also look at it. So these are 2 really good resources that you may find helpful in the future. Skin infections. I wanted to cover a few skin infections and general concepts behind management. And generally speaking, as you are probably aware, we categorize these based upon the source of infection. Bacterial based in skin infection, typically staph and streps. Viral, fungal, which is very commonly seen, and we see this in primary care a lot. The infestation, scabies, lice, and so on. And those are the general concepts and how skin infections are split. So let's talk about bacterial infections first. This comes back to distribution. So let's think about where these these bacterial infections can present. And they can present all over the body. Is it local? So in a very localized area of skin. Then consider the depth. Is it affecting the deeper layers? So is this a cellulitic picture? Or is it more superficial, which is erysipelas? In erysipelas, you normally have a slightly more defined border, and it's from a superficial skin layer. Organisms are typically, as I said, staphs and streps, which are causing these infections. In the history, really try and go deep and understand, is there a risk factor that's relevant? So things that I would be thinking about are, is there a source of injury? Has the patient knocked their leg, which has triggered this? Do they have ulcers? What is their blood flow like in the lower limbs, for example? Do they have a wound that has subsequently got infected? Always consider their immunostatus. Are they immunosuppressed? Because these patients are often developing these bacterial infections. And then we consider how we manage the patient. Just like we discussed with dermatitis, we consider the topical washes. So what are they using in the soap, as a soap or in the shower? And in these scenarios, this is where antibacterial washes can be very helpful. Dermal 500, wonderful. Chlorhexidine washes, wonderful as well. So you use them in the shower Generally, what I would suggest is you ask the patient to wet themselves. You then apply the wash, leave it on for a few minutes before washing off. Consider adding a topical antibiotic or steroids, so fustic acid, Fucibet, which has the steroid in as well, and then the oral antibiotics on top. Fungal infections are really common and can be quite tricky to treat. This is wrong. Apologies for that wording there. So when it comes to the presentation, fungal infections can present in all different ways. They can be very slow developing. They can develop slightly quicker. But most importantly, they are typically unilateral, so affecting one side of the body. They are often itchy. Occasionally, they can get a little bit wet, a little bit weepy. They're normally either being caused by yeasts, dermatophytes, or molds. So dermatophytes being tinea is often the common cause. When it comes to trying to diagnose this, you can take a really good history, as what we've spoken about. Sometimes we take scrapings, sometimes we take nail clippings. Nail clippings can be very good for trying to determine how we're going to treat this with oral treatment, so a fungal nail infection. Skin scrapings also can just guide us along. However, if you don't have this available, not a problem, because it's really the history of these that is most important. And how do we approach management? Avoid steroids. Generally speaking, in fungal skin infections, we want to avoid steroids because steroids can mask the infection. They can also actually worsen the skin and prolong the rash. So avoid steroid treatments if you suspect it's a fungal infection. Always consider what factors are causing this. Commonly, it's a moisture, wet skin. So can the patient, for example, get more air to their skin? Can they wash when they come home from work? Can they pat dry the skin? Anything to remove moisture will help. And then we consider treatments. Topical treatments are always the mainstay of treatments. So the clotrimazole type treatments, terbinafine, for example. Sometimes we use combination treatments, something like Lotriderm as well. And then there are also oral treatments if you're finding the fungal infection is not clearing. So this is how we would typically treat some of the common infections. So tinea corporis, so fungal infection on the body. This is normally treated with an antifungal. Clotrimazole, terbinafine are two very common ways of treating. Something to note and explain to a patient is that they should not stop treatment when the skin infection resolves, but try to extend it for 5 to 7 days, maybe even longer after resolution. Commonly, the minute this reaction settles, a patient stops the cream and then it returns very quickly. So extending treatment just helps reduce the chance of recurrence and fully clears the fungus. When we think about tinea of the scalp, so capitis, this normally requires oral treatment. So for us, we use terbinafine once a day for 4 weeks. We check LFTs. We just want to make sure the liver is all fine before treating. And sometimes post-treatment, we may also recheck LFTs at that point. And in children, it's weight-based. In the UK, we do not prescribe terbinafine for children in primary care. This is normally only prescribed by the consultant dermatologist in hospital. And then we think about tinea, so of the nails, so fungal nail infections, extremely common, very hard to treat. So what are our options? Always, always, always talk to your patient and actually offer them the opportunity to do nothing. So we can leave it alone. This is not dangerous. This is very hard to treat. And many patients actually don't want to treat. But if the nail is crumbling, it's painful, it's causing trouble, they don't like the look of it, then you can offer treatment. And nail paints, so amorolfin, for example, is a nail paint that can be very effective. However, it really needs to be used for long, long periods of time. So typically 6 months for the fingers, up to 12 months for the toenails. So it requires a long treatment, but it's very effective. If you are thinking about oral treatment, generally that's terbinafine or itraconazole. I've put the doses here that typically we would treat. You can either use itraconazole once a day, or more commonly now people are using pulse treatments. So this is higher dose for shorter periods of time. Scabies, a very common skin infestation that we see, and we see it quite commonly in the UK now. Often people don't consider it as the cause of the rash, but it's important for us to be aware. So it is from a mite, and typically we're seeing this in people who have very close contact with someone else who has scabies. Warm atmospheres, warm environments, warm countries are very commonly seen. Common presentation of this is erythematous, so red patches, plaques, little small areas like this that are extremely itchy. So pruritus is the main presentation, but the itch can start 1 to 3 months after the patient has become infected. So it can take time to build in the skin. You can see many different patterns. It's often inflammatory, so it's inflamed. It's papular, so small little raised papules. It can be generalized or it can be localized. So here, this is showing someone's back. This is a generalized, so it's quite extensively spread. You'll often see burrows. So this is a burrow here. As you can see, it's a linear burrow where the mite is traveling. On the back, it can be extremely itchy. So areas to always look at is around the armpits, around the truncal areas, around the breasts, around the buttocks, also within the groin. In men, always consider, are there any lesions on the penis or on the scrotum? And inflammatory nodules on the penis are very, very commonly seen and are pathognomonic for scabies. So if you see those in a men, it's commonly going to be scabies. It's all important to note that what starts with scabies can also then develop a secondary reactive rash. So this is where the body is becoming almost allergic to and reacting to the mite. So then patients can develop eczema, so dermatitis. They can also develop urticaria type rashes. So if you are seeing these patients quite late on, they may present to you with what looks like dermatitis or what might be urticaria. However, the cause is underlying scabies. Think about overlying infection as well. When it comes to treatment of scabies, there are multiple options. We typically use permethrin as a cream. It's safe to use in pregnancy. You do need to give some very clear advice to the patient. So this is used from the chin down. They need to cover the entirety of their body. They need to put in all the skin creases, so between fingers, under the breasts, behind, in and around the neck area, within the groin area. You leave it on for 12 hours before washing off, and you must treat everyone in the family. Another option is malathion. Another option prescribed in the same way. The only difference in guidance is that this stays on for 24 hours rather than 12. Sometimes patients are treated, you have cleared the scabies, however, they are still itchy. So the pruritus associated with scabies can often take 1 to 3 months to settle down. So they still are itchy even though they are clear of scabies. So in these types of patients, if you think there is ongoing pruritus, consider using topical treatments. You could use emollients, you can use some steroid treatments if there is areas of erythema. We use something called Urax, which is crotomatin, which is actually antipruritic, so it's helping with the itch. It's also an anti-scabies treatment as well. So it's continually working both ways. If your patients are not clearing after multiple failed treatments with creams, you may want to consider oral options, something like oral ivermectin. In the UK, we don't really use this in primary care, so this is normally seen in secondary care. It can be quite hard to find, it's extremely expensive. It requires some monitoring as well. So there is an oral option if needed. Last topic I want to discuss is pruritus, so the presentation of pruritus itch. Common finding, common presentation, very hard to investigate, very hard to treat. The first distinction to think about in pruritus is it acute, is it chronic? And we use 6 weeks as the distinguishing kind of timeline to determine that. We then want to classify it into generalized or localized pruritus. So generalized pruritus has a number of subgroups. So we consider, is it medication-based? Is it a systemic cause? Is it psychogenic? So is this psychological? A lot of patients actually have psychogenic pruritus. Is it aquagenic? Is it being triggered by water? But 50% of cases of pruritus have no cause. And this is where it's really hard to discuss with a patient and explain to them that we cannot find a cause, but that's very common. 50% we don't find a cause. The other distinction, or the group considering, is we have to consider is localized pruritus. These are only a few groups, and there are a couple of subgroups within that. So we consider something called brachioradial pruritus. This is a condition that you often see around the forearm, and then a condition called notalgia parasitica, which is this area here. So this is on the scalp, on the back, and in an area where patients can reach and itch. We then need to understand and think about what are the possible causes of pruritus. Medications, really common cause of pruritus, and these are just some of the common medications that we see that can trigger pruritus. The problem is that the pruritus can develop much later on, so they may start a statin, but actually the pruritus starts a few months later. But always consider the medications. Is there a timeline with that? We then have to consider systemic, so internal causes of pruritus. Malignancy is important. So is there a possible underlying cancer? We must think about thyroid. Are there hematological, liver, or renal causes of the pruritus? Is the pruritus actually just linked to a dermatological skin condition, such as eczema, scabies? Is it a pre-bullous disease? So many of the bullous disorders, so things like pemphigoid, start with pruritus for many months before the bullous disease starts. Is it psychiatric? Are there any other conditions that the patient is experiencing that are actually presenting with pruritus? And as I said, 50% we unfortunately don't find a cause for. This photo is quite interesting. It shows something called the butterfly distribution, is what we describe it as. But as you can see, this is the area that this patient can reach over their shoulder and itch and scratch. And now they have excoriated, so they have actually opened and broken the skin. How can we investigate these patients? History, history, history. So a really detailed, targeted history is the first and foremost port of call. We want to examine the patient, but don't just examine the skin. Think about the chest, abdomen. Are there any lymph nodes that could be indicating an underlying hematological disorder? Do they have any breast lumps? Is there any organomegaly, particularly liver? Do they have any neck lumps or swellings? Is there some sort of thyroid disease? We have to consider wider causes of the underlying pruritus. If we can't find a cause, then maybe we want to start investigating further. So there are a whole host of investigations we can consider. Blood tests are going to be probably the first and foremost port of call. So we might consider things like sending a full blood count. We sometimes send blood films. We think about iron status, kidneys, liver, thyroid function. Always think about immunosuppression. So HIV is really important here. Hepatitis as well. Pruritus is commonly seen as a presentation of these underlying immunosuppressed disorders. Has the patient been traveling abroad? Have they been away? And then we might want to consider other internal causes. So some of this will be picked up with the initial blood screen, but maybe we need to think about immunoglobulins and so on and so forth. Do we have access to chest x-rays? So if you might think there is an underlying lung pathology that is potentially causing this, maybe we need to consider doing a chest x-ray. We might want to check the urine dip. We also might want to look for blood in the stool if we think that this could be presenting from an internal bowel-based malignancy. At this point, we will do some of these tests in primary care and general practice, but if we still can't find the cause, often that is the point where we are referring these patients onto secondary care. So some of these investigations will be done in hospital. If we still can't find the cause, we have done all of these extensive tests and patients are still presenting with pruritus. By the time they are seen in hospital, we will often send them for CT chest abdo-pelvis, because at that point we are worried often about an underlying malignancy. So how do you manage pruritus? Very similar to eczema we discussed earlier, there are core themes of treatment. Topical-based treatments. We have to consider starting an emollient. Emollients, moisturizers are really important in managing pruritus and also advising the patient to use the emollient in the shower. Add in a steroid treatment because this pruritus is often coming from inflamed, irritated skin. Balneum Plus is a really nice urea-based product that actually can be very good for pruritus. You might want to consider Urax. So this is the same treatment that I mentioned that we use in scabies. So it has an antipruritic action. Other options could be things such as capsaicin cream. So these are slightly hotter treatments, heat-based treatments that can be helpful in pruritus. We then want to consider antihistamines, so oral treatments for the pruritus, but you need to give them longer treatment periods. So not just 1 or 2 days. Advise the patient to try it for 4 weeks or 6 weeks and then see whether it's had an effect. If the patient has tried something at home, so maybe something like loratadine, which you can buy, generally speaking, I go straight in and give them fexofenadine, which is what we use in the UK. It's non-sedating, it's very strong, it's very effective. Fexofenadine, although in the BNF is licensed as once a day, off license, we use it 4 times a day if we need. So it can be increased if the patient needs. If a patient's really struggling at nighttime, again, we might want to consider some of the sedative antihistamines that I mentioned that we use in dermatitis. Sometimes you might want to consider oral treatments. Now, generally speaking, we are not going to start these until we really know the cause and we would have ruled out an underlying malignancy, an underlying condition. In hospital, if we have no specific understanding of the cause of the pruritus, they have been investigated, very occasionally we might use some of these treatments. If we are still stuck, we can't manage the patient, phototherapy can be quite a useful tool, but this is always delivered in hospital. So moving on to a couple of cases before I finish. Case 1. A 17-year-old lady attends a walk-in clinic worried about the appearance of her skin. She's worried about how it looks. And she's developing white spots. They are spreading slowly. They're on her back. The skin is asymptomatic. And this is what the skin looks like. I'm going to try and see if I can chat. Okay. So can everyone still see my screen?
Yes, sir.
Okay, so someone's already put an answer in. Any other options or ideas as to what this could be? Good. So few answers already speaking. So the suspicion that this is pityriasis versicolor. But before we diagnose pityriasis versicolor, let's consider how we're going to describe this reaction. So does anyone, could people start trying to type in how you might describe this rash? So having gone through what I've explained, any thoughts of how you could describe it? So think about the distribution, think about morphology. Okay, so description-wise, how would we describe this? The way I would be describing it is using words such as pale, hypopigmented, so it's reduced pigmentation. It's quite a large area, and the word confluence is quite important. So you can see that these discrete areas have now joined to merge together, so creating a larger confluent area. There are some scattered lesions as well. The lesions are quite well defined. If you look here, these are really well defined areas. And if you were to feel the skin, you're going to see a very fine scale overlying. So management of this. So this is tinea versicolor. It's a yeast. As I said, the pigmentation can present differently in different skin. Reduced pigment, increased pigment. Sometimes you can get some erythema and scale. You could use something called Wood's light. We actually don't use this because we never seem to have it in hospital, but if you were to use a wood light, you can see a yellow-green fluorescence. But this condition doesn't need that. It's diagnosed clinically. And how would we treat it? So we use something called Nizoral, so ketoconazole-based treatments, antifungal shampoos. The advice of how to use this is really important for patients because often they don't have the right advice on how to treat. So I advise patients to stand underwater, so wash themselves first. You then use the ketoconazole and create a lather, so like a foam, put it all over the skin, and then sit outside for 10 minutes. Just wait while the shampoo is working, and then we wash off. Treat for 5 days in a row, and that would clear the skin. However, although you have cleared the skin, the rash has not improved. The rash will take many months to settle down. So it's about trying to give that patient confidence that you have treated it, but it will just take time to recolor. Sometimes you really struggle, you can't clear it. And in those cases, we do sometimes add oral treatments, so oral itraconazole, for example. Generally speaking, I would be suggesting before going down the route of orals, I would normally be trying ketoconazole once, twice, 3 times before making a decision on oral treatment. But giving the patient advice that it's going to take many months to settle is important. So another case, a 7-year-old boy attends with new lesions on his body. They're generally located on the leg, increasing in number, raised and red. This is what it looks like. In the chat, please try and describe what we're seeing, not just the condition. So someone's put molluscum. Can someone describe in the chat what they're seeing? Describe the lesions. Because this is quite a good, a good case to understand how to describe. And also any other options or causes of this particular condition.
Multiple maculopapular lesions.
Fantastic. Yeah. Umbilicated papules, fantastic. Dome-shaped papules, central umbilication. These are really good descriptions. This is exactly how we would want to describe it. So some words, thoughts of what I was looking in and how we could consider describing it. It's clustered. So we used that term earlier. But as you can see, these discrete, well-defined lesions are actually clustered together. They're shiny. If we were to see them under a better light, they look small, they look shiny. Umbilicated. This one particular has the classic umbilicated pattern. Often these become quite inflamed and irritated, and that's why these ones in particular are looking so erythematous. Often you also can see some scale overlying in certain lesions. So as someone has mentioned already, this is a classic case of molluscum. Very commonly seen, we see it quite often at home as well. It's a pox virus. But importantly for this, understanding how to describe it, being clear in your mind what it is, giving the diagnosis is often all we need to do. So there are no real investigations we consider for this. It's a clinical diagnosis. And what can we do about it? These can look quite unsightly, particularly because we see them in children. Parents can be very worried about them. But these are self-limiting, and explaining that to a patient can be quite helpful so they understand that actually they don't need to worry about it, they can leave be. The only problem is that it takes many months to settle, 6 months, 9 months, up to 12 months, sometimes even longer. But if a patient is happy with these lesions, they are happy not treating, then you can do that. But if you are considering treatment, the best treatment that we have available at home is potassium hydroxide-based treatments. Now, I don't know if this is what you have available locally, but things like Moludab is a classic treatment that can be very good. So Moludab is what we would prescribe twice a day until they become very angry and inflamed, or you can continue treating up to 2 weeks. So you're trying to instill a reaction and then you stop treatment and then it can help settle down. If topical treatments are not working, and if you have access to cryotherapy, then you can treat them with cryotherapy. Generally speaking, though, these are going to be children. They're not going to tolerate cryotherapy well. So we would always, in primary care, just treat topically rather than going for anything further. But I have seen this done in hospital where the children were really upset and struggling, and we did treat with cryotherapy. And you can also treat these surgically, so we can shave, curette them if needed, if they're particularly large lesions. So, nearing the end of this presentation now, resources. Here are just a few really, really good resources that I use particularly, and my colleagues use as well, that you have access to. PCDS, this thing at the top, is absolutely fantastic. It is pitched at primary care level, so it is for GPs, and it gives you an incredible amount of information on all conditions, how to investigate, how they present, what we might want to consider, and really clear practical tips on how to treat. I use the BAD leaflet for patient information leaflets. These are fantastic. They're very clear. They're already created. You can print them off with a QR code. You can send them a patient a link. It has all the information a patient might want to consider. And it's also really helpful for doctors because you can actually use it with the patient to talk about the different treatment options. If anyone here is doing lots of surgery, and I'm not sure if you are, but the BSDS link here, which I've written here, is fantastic for really good surgical advice, so practical surgical advice for skin surgery. So it will cover everything from things like local anesthetic doses, risks, operating, for example, if a patient's pregnant, different types of surgical approaches, the types of sutures you might want to use. So if any of you operate, then this is really, really helpful and worth a good read. I'm sure many of you know DermNet, so this is used globally as a fantastic resource. I find this very good for a wider understanding, but it doesn't often give clear practical tips, which we want to know if we're seeing a patient in a consultation room. So DermNet is very helpful, but I would say PCDS is probably the most helpful resource. And then St. John's, which is in London, one of the specialist dermatology centres, also has a lot of really good patient information. Again, this is called the St. John's Derm Academy. If you Google that, you'll find some fantastic information available there as well. So, conclusions. I hope I've tried to explain and cover some general background to dermatology in primary care. With all the conditions and all the cases we talked about, the importance of a history can't be understated. Understanding background, history, how the rash or lesion has evolved will really help, but then also describing it in considering morphology, distribution is really helpful. Investigations are really based around what you have available and what the patient can afford and what is needed. An awful lot of these skin conditions that we see in primary care don't need much investigations, and you actually might just be able to trial different treatments to see which one is working instead. The management principles for all skin conditions follow the same pattern: education and good advice and resource. Think about the general measures, so that is removing triggers if you can, cutting nails, clothing, so general advice. Then consider emollients, soap substitutes, what they're using in the shower. Then step up to the topical-based treatments, whether that's steroids, antifungals, combined products, and then consider your oral options. And as I said, in dermatology, the really nice thing is that generally speaking, these patients are not unwell. So we have time to trial, review, see how the rash is developing, and then consider changing treatment. So here are a few references. These are some of the things that I used for the presentation. And that's the end. Thank you.
Thank you, Sagar. That was really very informative, very useful, going back to the basics, especially emphasizing the need for history taking. I like that because, you know, most of us, once we see a rash, we sort of think of the diagnosis first thing rather than going back on the history and taking the time. So very helpful, really good, sensible ideas as well. Thank you very much. Cheryl, maybe yeah, please go on.
I was just going to say, sorry, I was struggling. I couldn't see the chat at the same time. So there's a few questions I've seen on there. So I might just go through some of those if we've got a few minutes left, if that's okay. So someone asked, is lichenification pathognomonic for chronic eczema? So just to remind us all, lichenification is that thickening process of the skin where it starts to thicken and become quite rough. I wouldn't say pathognomonic for chronic eczema. You can get lichenification in conditions like psoriasis, but it is classically seen in eczema. So a lot of patients might say, oh, you know, this rash is new, I've never had it before. But actually, when you really start to feel the skin, you start to look around the wrists, the ankles, the knees, you'll start to see that lichenification process. And it tells us that this has been going on for much longer than expected. So not pathognomonic, but very commonly seen. Someone here has been using urea-based products for eczema. I know I don't know what emollients you have access to. Urea-based products are fantastic, particularly when someone has eczema that is very itchy. So in a lot of eczema, if it's not too itchy, actually most emollients will work quite well. But if you're finding that itch is the primary presentation, that's what's really bothering a patient, then yes, urea-based products are fantastic. They all come in different percentages. If you can find a 10% urea-based product, then it really will work well for the itch, as well as actually moisturizing the skin. Tacrolimus, so immunomodulators can be used for any part of the body. The benefit of protopic, for example, so tacrolimus and pimecrolimus, the reason why we sometimes use them is they are steroid sparing. So they can be quite nice for patients, particularly thinking face is a really common use of where we see it in the UK, where we can't keep giving them steroids. We can't really step up and use potent treatments. So using something like tacrolimus can be helpful. Yes, you can use it on the legs, but you may find actually you're probably better off just going with a much more potent topical steroid on the leg. So this is you know, very hardy skin. It's not delicate skin. You can use something much stronger like Dermavate, and you might find you are just needing a much more potent steroid for a couple of weeks, and that overall is actually going to be quicker to treat than using something like tacrolimus. The other thing to note is that it's, I believe, very expensive. I don't know the costs for this treatment where you are, but it's incredibly expensive in the UK. So obviously a big consideration. That's why often actually you don't see it used that often privately because of the cost.
I was just looking at the cost of tacrolimus. I see that it's about $40 US. So, yeah, it's interesting. Please go ahead.
And it comes in very small quantities as well. So it's quite a it is a pricey treatment. A really good question. So patients living in tropical climates, hot, humid, they don't like the greasier creams. So what can we do? It's not an easy option. So it's quite common that the treatments that we recommend, so the best treatment if we all had eczema would be using a very, very greasy treatment, like Vaseline or petroleum type jellies. So really grease, that would be the ideal scenario. The reality is it's not suitable for everyone. How I would approach these patients is that it is better they are using a smaller amount of cream that they are happy with than not using anything at all. So if we keep advising them use something greasy and you know they're not going to use it, then no one wins in that case. It is better to go with something that they are happy with. So for example, for those of you who So let's say your patients are going to work. They might not want to use a greasy cream. That's not a problem. So what you might find is saying, actually, let's use something that is like a lotion. So a cream or a lotion, they absorb better. They're not greasy, they're not shiny. The patient might be more willing to use it when they go out in the day. But maybe when they are at home, when they're in their home environment, maybe they can use a slightly greasier option before bed. So you just have to tailor the treatment based upon each patient. Someone's also asked about sharing the slides. Very happy to share if that will help. I can send them on if you find it helpful, because on there I've also included all the resources and links. So I would say, yeah, not a problem. If you'd like, I can send them through, and then I would really strongly suggest you try and click on some of those links. They're fantastic. There's some really good resources for your practice at home.
There is a GP website actually, so we can put it onto there. We'll do that.
Okay. Oh, there's some more questions. So let me. So someone's asked about resistance to permethrin. Permethrin. Do you for scabies? What are the typical treatments that you use for scabies? Because I imagine it quite commonly seen.
Very common. Ser bathong the scabies are.
Laurel's cream. Laurel's cream. Yeah.
Like clear. So permethrin.
Yeah, permethrin cream.
If you're finding that if you're finding that it's not settling down, then I would consider trying to switch to something like malathion if you have that available. That's what we use. We try and switch between topicals a few times, and then generally then the patient might need ivermectin. I've seen some of these patients in hospital in my hospital job, and even when they get into hospital, most patients are not actually resistant to the topical treatments, but they just need more guidance on the correct use, also making sure everyone is being treated. And we generally keep retrying the topical treatments. Very few people end up on ivermectin because of the complications of it. I don't know any other options apart from oral ivermectin, but I can certainly find out, and maybe I can send them through to you after with the slides, some other answers to that. Vaseline is a really good. Someone's asked about Vaseline. Really good question. Vaseline is actually very pure, so it's a really nice, clean, pure petroleum-based product. So it shouldn't irritate the skin. It shouldn't have many additives. If you find that a patient finds it sensitive, not a problem. Try and switch over to something else. What actually is we generally find is that it's not Vaseline itself that is irritating the skin, but when someone's skin is very raw and irritated, any emollient, any lotion, any product we put on can irritate initially for the first few days. So if you're finding that patients are struggling to put or to use emollients in that initial period, you could try different things. You could ask them to put less on the skin. You could ask them to put a little bit on for maybe a couple of hours and then gently wash it off. Try and see if you can build up. But generally speaking, once the inflammation starts to settle, all the emollients are tolerated slightly better. And if you still find it, then switch over. So something like I'm trying to think. So things like aqueous-based products. We use products like Cetraben, E45, Diprobase. These are kind of slightly greasier type products. 50/50 is another type of greasy product. There's a whole host of different options. I generally find that if a patient's not happy, I just switch over, because it's better we try something else than not at all. A question again about scabies is repeating treatment. I would say that I always suggest repeat treatment. So you treat once, you treat the whole family properly, and then repeat the treatment again. Some of the guidance, I believe, and I need to have a look at it, it says that the repeat treatment, the second treatment, doesn't always need to be the entire family. generally speaking, back home, we just treat everyone twice, but the second treatment can just be the patient alone. The idea being it is trying to give yourself the best chance of resolution. As I mentioned, a lot of patients will come back and think that it's not cleared, it's not treated because they are itchy. So just remembering that that itch can still continue for 4, 5, 6, 8 weeks potentially after eradication is important, because that's actually what might be happening. So they are still itchy, but they are eradicated. So maybe just giving yourself a little slightly longer window before considering it's cancer, it's not treated is going to be helpful. So I hope that was oh, something about so someone's asked about laser treatments. I actually don't know about laser treatments, so I have not seen that, but I will I will certainly have a look at that, and I've made a note on a couple of questions, so I might have to come back on some answers if that's okay, and find out. I don't know about laser treatments regarding tinea.
Thank you. I think we've gone through. Sagar, that was really useful. A lot of questions, and I think yes, thank you very much. And I'm sure they would love to have you back again for more dermatology. Sagar Jesuပါပဲအားလုံးတော့ထပ်ပြီးတော့ဆရာ Sagar Patel လို့ထပ်ပြီးတော့ book လုပ်ထားလိုက်အောင်မယ် dermatology ထပ်ပြီးတော့ဆရာတို့လိုချင်တဲ့ topic လေးတွေကိုchat ထဲမှာထည့်ပေးပါဒီ dermatology နဲ့ပတ်သက်လို့သိချင်တဲ့ဟာလေးတွေကိုလေနောက်တစ်ခါလုပ်လို့ရတယ်ပေါ့နောက်တစ်ခါ webinar လေးလုပ်လို့ရတယ်ပေါ့ I've asked them to put some topics on dermatology they would like in the chat, and then
I did want to ask, I didn't put anything about skin cancer. Is skin cancer a common presentation that you are seeing? And then the other question I had, which we could maybe do as another type, is do many people do a lot of surgery in primary care? So the GPs are treating surgically?
I think quite a few. There's a few that do minor surgery actually for I don't think for skin lesion. They probably do. Skin lesion minor surgery low lamadi.
Hello, Sia.
Hi,
Sagar, nice to meet you. Thank you for your very useful talk. And Sia, the model minor surgery low jare was the low there, Sia. Or not be the a state infection in one. The incision drainage low there, sebaceous cyst requires, Sia. The never baba, Sia.
Okay, so
Skin
what's
cancer got suspecting low help.
So skin cancer, so they do removal of warts or sebaceous cysts and minor skin lesion, but any hint of a skin cancer is usually referred to secondary care. Skin cancer,
Okay, that might be something happy to do next time if people want to do more surgical a surgical discussion about approaches and the practicalities, particularly things like lipomas and, as we said, cysts, moles, and so on, if anyone's interested.
Thank you very much.
Thank you.
Thank you. Sarah, I'll tell you up here tomorrow, no? There's some melanomas. Yes, people are getting melanomas. So maybe skin cancer could be a topic as well. Diagnosis of skin cancer, SCCs, rodent ulcers. Yeah. Thank you. That's a women touch your pay later.
ဟုတ်ကဲ့ဆရာဟိုဟာ email လေးတွေသူတို့တစ်ချက်ပို့လို့ရအောင် PPT slide လေးတွေလေပို့လို့ရအောင်ဆရာအဲ့ဒါ email လေးတွေရေးခိုင်းတာဟုတ်ဆရာဒီမှာတို့ဒီကနေပြီးတော့ပို့ပေးလိုက်ခဲ့ပါဆရာ Thank you sir.
They're collecting their emails, so they'll share the slides with them, so that'll be fine. So we can go. Thank you, Sagar. Alum cheers dinner, no?
ဟုတ်ဆရာကျေးဇူးပါ
ဒီမှာတော့
Thank you ပါဆရာတို့ဟုတ်ဆရာတို့အားလုံးလေဟိုဒီဆရာပြောသွားတဲ့ presentation ရော PowerPoint ရောကျွန်တော်တို့ရဲ့မြန်မာ GP Facebook page ရောမြန်မာ GP website ကိုနှစ်ခုလုံးမှာတင်ပေးမှာဖြစ်ပါတယ်နော်ဆရာတို့တွေမှပြန်ပြီးလေ့လာလို့ရပါတယ်ကျွန်တော်တို့ပြန်တင်ပေးပါဖြစ်ပါတယ်တက်ရောက်လာကြတဲ့ဆရာဆရာမတွေအားလုံးလည်းကျေးဇူးတင်ပါတယ်ရှင်အားလုံး good night ပါ
ကျေးဇူးတင်ပါတယ်
good night ပါ